So we can go ahead and get started. Thanks everyone for coming. This morning we have kind of a special focus on otolaryngology for the internist, and our first speaker will be Dr. Nina Liu, who specializes in facial and reconstructive plastic surgery and facial paralysis as well.
Great, thanks so much for having me, everyone. I wanted to just give a presentation a little bit about facial paralysis and treatment options and just what a general internist hopefully should know when they're in practice. So thanks again for having me. Let's see. Great, no disclosures. So our goals for today, a little bit of workup and diagnosis. This is focusing mostly on unilateral facial paralysis. Bilateral facial paralysis is kind of a whole nother topic, especially synchronous paralysis. And then types of facial paralysis. So actually there's a pretty wide variety of patients. It's not all just the typical stroke patient that you think of. And then the surgical and non-surgical treatments that are available for patients you might see. So first diagnosis, when you see a patient with facial paralysis, it's just don't default to Bell's palsy, right? You have to consider a little bit of why they have it. There's, again, focusing on unilateral palsy. There's a wide differential diagnosis, and just keeping it broad. A large chunk of them are not typically diagnostic dilemmas. They're usually fairly obvious in the history. If somebody had temporal bone fracture or surgery, or they were born this way, strokes generally are not typical diagnostic dilemmas. And then most people with an otologic history, ear draining, frequent ear infections, those don't typically provide a problem for most diagnoses. Neoplastic, inflammatory, infectious, and idiopathic are typically discernible from a comprehensive H&P. And we're just going to focus on a few topics, or a few diagnoses that'll be most common, as well as ones that are more head neck focused. So there a lot of the presenting symptoms focus in the head neck region. So first is we're going to talk about idiopathic paralysis, Bell's palsy, and this is technically a diagnosis of exclusion, but it's probably going to be the most common patient type that you'll see in clinic. And we think probably it's from a herpes simplex virus reactivation, but nobody really knows for sure. And of acute onset facial paralysis cases, it's up to 80%. And I think this range of percentages just depends on what kind of practice setting you're in. So in the primary care setting, probably higher. In like the oto setting, probably lower. We tend to see more tumors and things. And then it's really important just to remember the typical course of Bell's palsy. So these patients usually have facial paralysis on one side of their face. That affects all the branches of the facial nerve, and it is fairly rapid in onset. Generally speaking, they progress to full paralysis within 72 hours. It's not uncommon for them to say that their tongue feels numb, and that's honestly most of the time more of a taste alteration than it is true numbness of the tongue. But sound sensitivity due to effects of the stapedius muscle in the middle ear, which typically dampens sounds, but when it's paralyzed, it doesn't have that function, and so loud sounds sound even louder. And then ear pain is another common kind of symptom that patients might present to you when you look in their ear looks totally fine. And then the other important thing is that a comprehensive history and physical exam is otherwise negative. There's really nothing else that is showing up. And the treatments are steroids, antivirals, and eye protection. And so, the steroids is, I think, pretty much settled. Everybody gives steroids for Bell's palsy, and I think antivirals are really becoming pretty much routine as well. Their most recent Cochrane review on antiviral treatments for Bell's palsy shows that even though there's not in a placebo trial between antivirals and steroids and placebos and steroids, although there's not really much of an effect on rates of incomplete recovery, there might be a reduced effect of long-term sequelae, such as synkinesis and crocodile tears. I'll talk a little bit more about synkinesis coming up. And really no adverse events, although there's low certainty evidence and not very many studies on it. So probably low risk and possibly important in preventing long-term sequelae. Our society guidelines for the American Academy of Otolaryngology, specifically oral steroids should be started within 72 hours of symptom onset. And then antivirals can be used in combination, but never alone. And then you might hear of surgical facial nerve decompression as a treatment in acute paralysis. And this is somewhat of a controversial topic, but I have here a husky dressed as an otolaryngologist. And so here is where an otolaryngology consult may come in handy for you. And so the reason why it's so controversial is because the main study that it's based off of was actually, multi-center randomized prospective clinical trial. And this was back in the late 90s, and it was at Iowa, Michigan, and Baylor. And just a simplified summary of, what the study was, they looked at patients with acute paralysis, and depending on the day from paralysis, the patients would show up. Obviously, they were capturing these patients very early. If it was from day 3 to 14, then these patients would get an ENOG study. And so an ENOG study, electroneurography, is essentially when surface electrodes and sometimes needle electrodes are used to measure the electrical activity, an EMG essentially. It's like a stimulated or voluntary EMG. And that can give you a percent degeneration of the nerve compared to the normal side. So this is typically only used in unilateral facial paralysis. And so when patients had less than 90% degeneration of the nerve, so they had at least 10% or more of the nerve that was still functional, they continued on the prednisone route. And then if patients had greater than 90% degeneration, they were recommended for facial nerve decompression surgery. And what they found was that in the patients who had less than 90% degeneration and got steroids only, most of those patients recovered just fine on their own. So the House-Brackman scale is a scale you might have heard of already, but it's from 1 to 6, and 1 is normal and 6 is totally paralyzed. When the nerve was greater than 90% degenerated and surgery was performed within 14 days, there was a significant difference in the facial outcome of those patients. So the patients who received surgery, 91% of them ended up with a fairly normal House-Brackman grade at the end. And then those who only received steroids, a large portion of them ended up with an inferior facial nerve outcome. And then when they compared between those patients receiving surgery, so greater than 90% degeneration, and then receiving surgery before or after 14 days, they found that after 14 days, these patients actually tended to have worse outcomes compared to before 14 days. And so really, this is the trial that, and a few things you might notice. First of all, these are really low numbers, right? And this is the main trial that is kind of the basis for a lot of our surgical decision-making around facial nerve decompression. And so, what's the big deal with decompression? Well, the facial nerve, as it comes out of the brainstem and enters the temporal bone, it's the thought is that when a viral reactivation, such as HSV, causes swelling of the nerve, when it's in a confined bony canal, that causes a relative compression of the nerve. And so the theory behind facial nerve decompression is when you unroof the nerve from that bony canal, it then takes off that pressure. And so if you're truly to decompress the nerve based off of that, philosophy, you have to actually enter the intracranial space, lift up the temporal lobe, and actually drill off the bone of the IAC along the entire temporal bone. And so it's not a easy 1-hour surgery. It's fairly involved. And so the other things that, from the trial are this decompression, theoretically, in order to be effectively done, should be done within the first 14 days of the paralysis onset. And you all have seen, I'm sure, patients who are coming at, day 10 or even after 14 days. So a lot of patients really don't fall into that strict criteria if you were to follow it. And then even if they do, they really need electrodiagnostic testing in order to help with surgical decision-making. It also provides prognostic information, the ENOG, and so I don't think it's necessarily wrong to get that for patients who are really concerned or, really want to have that information, but it may not change our decision-making in terms of surgery. And then of course it requires temporal lobe retraction. And so, if you have highly educated patients, they might come in and ask about this. And so, these are kind of the factors to know when you're educating them. So moving on to prognosis, gradual improvement in Bell's palsy occurs over weeks to months. But the key here is that basically all patients should have some signs of recovery by 6 months. And so, patients will ask you how quickly they're going to recover, and you can tell them 85% begin recovery within 3 weeks, and then pretty much everybody recovers within 6 months. The kind of natural course of Bell's palsy recovery is, again, rapid decline over the course of, at the most, 3 days, and then a gradual improvement over the course of weeks to months, and then 70% go back to normal. They have no really residual effects. But actually 30% of patients end up with suboptimal facial function. And so we'll talk a little bit more about this coming up. That's a pretty high percentage of patients that don't end up with a normal facial function. I think important to, let patients know about that. And of course, there's this very brief window for decompression for those patients that, meet all the criteria and also are interested in that type of surgery, which, quite honestly, a lot of patients are not. And so, again, I really want to emphasize that complete flaccidity lasting beyond 6 months is very unusual. A Massachusetts Eye and Ear Institute study looking at Bell's palsy cases over the course of 5 years through over 300 patients. Only 5 of those patients had flaccid paralysis, so in, where their face is drooped and they're unable to move it beyond 6 months. And then 4 out of those 5 were actually found to have malignancy that was significantly delayed in diagnosis because they had presumed Bell's palsy. And only 1 out of those patients truly went on to have delayed recovery. And so this is just really important to know when you first see your patient in clinic. You're telling them all about Bell's palsy, why we think it happens. This is a, there's a potentially a surgical option up front if they're falling in that the specific criteria and get the electrodiagnostic testing. But really key is that at 6 months, if they don't have any improvements, that we actually should exclude Bell's palsy as the diagnosis. That's no longer considered Bell's palsy. And we should be looking up alternate diagnoses. And so an algorithm proposed by that same group, the Mass Eye and Ear Institute, is actually, so, first they are in the Northeast, and so they get Lyme titers on every patient because it's such a high prevalence there. I don't think that necessarily here this is a part of our algorithm, and actually maybe you guys can educate me on that, whether or not you are getting them. But for most patients that I'm seeing with delayed Bell's palsy, I don't see that they've all gotten Lyme titers. If they're presenting early on, getting the ENOG is an option for them. And then you continue to evaluate them, on a monthly or every other month basis until they either improve, or if they do not, then they're at 4 months, actually, they propose contrast enhanced imaging that includes the parotid bed, the temporal bone, and the brain should be then considered. And they say this at 4 months in order to decrease the delay in diagnosis of, potential malignancies. And then they go so far as to say if the initial imaging is negative at 4 months, that you continue to observe them, and if they continue to be flaccid, that you should repeat imaging. And if that imaging is negative, you should continue to pursue an alternate diagnosis and even consider biopsying the facial nerve and to look for an occult malignancy. And this has been reported that an occult malignancy that's not showing up on imaging does show up on biopsy. And so this is, again, a time where, your local friendly otolaryngologist might come in handy for those patients who aren't recovering from Bell's palsy. So moving on, and I can't see the chat, I guess, so if any questions come up.
There is one question maybe before we move on. So as a group of primary care providers in the audience, when do you think patients should be referred to you to discuss surgical decompression of the nerve or intervention?
Yeah, so we're always happy to talk to patients if they have questions or if they just want to know more about that. But if we're seeing a patient after 2 weeks and they haven't had electrodiagnostic testing and they don't really want to have a large surgery where, you know, we have to lift up their brain and do, you know, a temporal bone decompression, those patients don't really, we're happy to talk to them, but they probably won't be getting surgery. It's the patient who is presenting early on, so within 2 weeks, who would consider having a facial nerve decompression surgery and is completely paralyzed. That's really key, is that if they have some return of function, some movements at all, then they absolutely don't qualify for that surgery. It's the patients with complete paralysis presenting early that really could qualify for a facial nerve decompression surgery. And so one of the keys is actually, you know, you want to make that that consults urgent or almost emergent so that we get them in to be seen relatively quickly. Because if they move out of that 2-week window, well, it's not to say you couldn't still do it. It's just that the evidence isn't supported, that, you know, that main study that everybody quotes and follows isn't really supportive of surgery after 2 weeks. That makes sense. And I think a lot of these patients present to their primary care physicians, but a lot of them also go to the ER and then get follow up with you guys afterwards. And so you might be seeing them after 2 weeks, in which case, you know, I have a lot of really well-educated patients who will come in with very specific questions. And so I want you guys to be educated on, you know, that facial nerve decompression aspect. Does that answer the question, hopefully?
Yeah, that's great. Super helpful.
Great. Okay, so moving on, and you know, I'm not comprehensively discussing all the different causes of facial paralysis, but just a few that tend to come up from an otolaryngology standpoint. So Ramsay-Hunt syndrome, fairly similar actually to herpes zoster, or I'm sorry, Bell's palsy, but it's varicella zoster virus instead of herpes simplex virus that we think is what the cause is. And, you know, the two key presenting symptoms that are different is a vesicular rash. Typically, it's on the conchal bowl, EAC, or along the tongue, the chorda tympani. Providing taste sensation to the anterior two-thirds of the tongue is the pathway for that. But really any cranial nerve distribution, if they have a rash on their face anywhere, you know, qualifies. And then herpes zoster syn herpetae, so without the lesions, is, you know, a kind of a described phenomenon that's out there. It's much harder to diagnose. I think if somebody's having really severe pain, not just a little earache, but just really severe pain, it could be considered, but it's hard to differentiate because it would involve actually looking at varicella zoster, you know, viral load or in the CSF, or, you know, antibodies that are spiking. And so it's just something to realize, though, that it can happen without the actual rash. And then vestibulocochlear symptoms tend to be more common with Ramsay-Hunt syndrome. So if patients say they also have hearing loss and tinnitus and vertigo and nausea, vomiting with their facial paralysis, then this is something that, you know, we should think more about. And why it's important, if you think back to that natural course, so the Bell's palsy, most patients recover. But actually most Ramsay-Hunt patients don't recover normal function. Most of them have some level of residual facial palsy afterwards. And so it's important to have that in mind when you're talking to these patients. I think antivirals for Ramsay-Hunt is pretty established, and, you know, gabapentin or other kind of neuropathic pain relief is important. Eye care is especially important in these patients because they can develop herpetic keratitis of their cornea, and that, along with the inability to close their eye, can lead to corneal ulcerations that cause blindness. So I feel like ophthalmology consults for these patients early on is really key. Lyme disease, you know, this is something that I don't tend to see as a presenting symptom very often, but something actually primary care physicians probably see a little bit more. But typically headache, fever, fatigue, arthritis, you know, a rash, although the rash typically, there's an asterisk there because the rash typically isn't present on presentation. once patients come in to be seen. And then bilateral palsy is much more common in Lyme disease. And this is diagnosed via serum studies, ELISA and Western blot. And then there's early high false negative rate for these patients. And so if there's a high clinical suspicion, then retesting is important. And then, treatment is really more antibiotics. Lyme disease can reactivate herpes simplex virus or varicella zoster virus. And so oftentimes when you have paralysis from this, adding on an antiviral is done to prevent reactivation of herpes simplex and a Bell's palsy on top of a Lyme disease. So the steroid role in Lyme disease is actually somewhat unclear. There was a retrospective study done. It was only about, I think, 40 patients or so, but they looked at patients who had Lyme disease who, were started on steroids with their antibiotics versus, antibiotics alone. And they actually found higher rates of synkinesis in the steroid group. Now, given that was a small study and it was retrospective, but, it just kind of lends more weight to the fact that we don't actually know if steroids is definitely indicated. And, I trained partially on the Northeast where Lyme disease was much more prevalent. And so I looked when I moved here in the state of Washington, it's pretty rare to get Lyme disease here. But it's possible, 34% out of, or 68 patients over the course of 4 years, which is not a lot. And this is mostly actually, I think, out in Eastern Washington. But for those of you in training, you may not stay on the West Coast, you may go to the East Coast, and this might become much more relevant. So inflammatory diseases, Melkersson-Rosenthal Syndrome, it's just commonly tested in otolaryngology and something that, all the presenting symptoms are in the head and neck. It's essentially, it's asynchronous and oligosymptomatic. So patients don't present with all the symptoms at once, and they may not get all the symptoms. And, the 3 top ones is really recurrent oral facial swelling. So swelling of the lip, swelling of the tongue, and then recurrent facial palsy, that's progressive. So it tends to, happen, and then they might recover, but not all the way. And then they'll have another episode of paralysis, and then they'll recover, but not all the way. And it kind of, goes down in an undulating fashion. And then fissure tongue, this common appearance of fissure tongue here. And there's other smaller or less kind of pathognomonic findings, such as cheilitis and rash and nodules and vesicles. But the first 3 are really the most common. And diagnosis, quite honestly, I'm not the one typically diagnosing this other than from a clinical standpoint, but CSF can be looked at for elevated protein levels, biopsying the involved tissue, and then imaging can show, enhancement along the facial nerve as well. And it also helps rule out other causes of facial paralysis. And so these patients typically are treated with steroids, and then they can also get facial nerve decompression if their ENOG and EMG is showing kind of progressive decline in their facial nerve function. And so the natural history of basically everything other than Bell's palsy and Ramsay Hunt is for tumors, this gradual decline over weeks to months. For inflammatory diseases, and this is geniculate ganglion vascular malformations or other systemic diseases, kind of this undulating up and down, but overall a gradual decline. And then tumor or trauma, where you have a sharp decline, acute decline, looks very similar to Bell's palsy, but then just never recovers. So that's also abnormal. I just wanted to throw out other rare causes of facial paralysis. We're not going to talk about these today, but other things to just keep in mind. This is just a small snippet of, the overall patient population. So plug, always remember eye care. Basically every patient who comes in with facial paralysis, you should talk about this. They have, because their orbicularis is paralyzed, they're not able to really close their eyelid. Their lower eyelid is ectropic and loose. I recommend this lubricating eye gel. that's preservative-free. And the key really is the preservative-free aspect of it, because that allows them to use it much more often. If you have the preservative type of eye gel or eye drops on the box, the patients won't use it more than every 4 hours, because that's what it says on the box. And this they can use up every hour, every 2 hours. And then for those who are refractory to just gel and ointment alone, these clear eye patches really work. They work as a moisture chamber. It's like a little terrarium on your eye. You know, it prevents the moisture from evaporating. And then the clear ones also allow for patients to continue to see some through that eye. And then an ophthalmology consult if they're really having issues. From a surgical aspect, you know, placing an eyelid weight, eyelid loading is an option, not typically for like patients who you expect recovery and over the course of months necessarily, but for patients with prolonged facial paralysis and inability to close their eye. Essentially, the theory behind it is that, you know, orbicularis oculi closes the eye, but the levator muscle opens the eye, and those are innervated by 7 and by 3. And so cranial nerve 3 is not affected in Bell's palsy or other types of facial paralysis typically. And so patients can still open their eye, but when you add in a weight on their upper eyelid, when they try to close their eye, the brain shuts off, you know, the the activity to the levator muscle, and it allows the eyelid to come down and aided by gravity with the extra weight on the eyelid. So they're still able to open their lid, you know, but they're able to close it a little bit better. This doesn't really replace your blink function because it's not very rapid, the closure, but it does, you know, does help quite a bit. And this is an example of a patient where we had just placed this eyelid weight in clinic, and it's just a small incision. It can be done under local anesthetic. It can be taken out under local anesthetic as well, so it's reversible. And it's helped her close her eyelid quite a bit. For patients who don't want something surgical, scleral contact lenses are another great option if they're kind of failing the usual lubrication, eye drops, eye taping kind of scenario. And it's essentially, this is a specific type of scleral contact lens, but you know, the Eye Institute here makes them for patients as well. And it's essentially a large bandage that holds you know, a liquid reservoir over the cornea and prevents it from drying out. The key though is that it's huge. So this is a normal contact lens and this is a scleral lens. It's much bigger. So it's you know, more difficult to take care of and get in and out for patients, but I have patients who really love it. So moving on to types of facial paralysis. Most of you probably are familiar with this type of flaccid paralysis. And you know, it's quite obvious. This gentleman cannot close his eye, his face is drooped, his nasolabial fold is a face, his mouth is twisted over to the normal side, you know, he can't raise his eyebrows, he's lost wrinkles of his forehead. And this is a patient who actually has spastic paralysis. So at rest, she looks relatively normal. But then when she's moving her face, like raising her brow, you notice that there's twitching of the mouth and that she really can't raise her right eyebrow very much. And when she closes her eyes, again, she has twitching and then she has spasm. See how deep her nasolabial fold is on this side? And when she smiles, even though she's got so much kind of spasticity on this side, she really doesn't have much elevation or dental show on that side. So this is actually also a patient with facial paralysis that probably is not, you know, necessarily picked up as easily because she does have some movement, but it's an abnormal type of movement. And in that 30% of Bell's palsy patients that don't really don't have complete recovery, this is a typical progression from a patient who has had flaccid paralysis from presumed Bell's palsy that progresses onto spastic paralysis. So, you know, you can see how her eye on this right side is really squeezing shut when she's smiling. And that's because there's an abnormal connection between her smile center of her brain and her eye closure center, where the nerves, the wires kind of get crossed and the signal gets sent to the wrong place essentially. So when she's trying to smile, she's getting a lot of eye squeeze instead of commissure elevation. And then at the same time, she's able to move the mouth some, but she's not really able to move it fully upwards because there's too much activation probably of the muscles that pull her lip down. And so patients can progress from flaccid paralysis to spastic paralysis. And in, for example, Bell's palsy patients, this can occur over the course of a whole year after their Bell's palsy presents. And so, you know, the majority of patients, this won't happen, but a decent number will have some residual effects such as this. And the key is that many treatment options exist for all types of facial paralysis. And so there's things that can be done for these patients. And it's not something that patients tend to not bring it up sometimes because they feel like it's a cosmetic problem, or, you know, nothing, they've been told nothing can be done for it. I feel like this is kind of my campaign public service announcement that, hey, treatment options exist, and you know, we should be telling more patients about them. So just starting with the non-flaccid or spastic paralysis, the mainstay of treatment for this is really Botox or chemodenervation and facial therapy. The surgical kind of counterpart to that is selective neurolysis and myectomy. So it's a more permanent type of, you can think about it like permanent Botox, where you actually are cutting specific nerve branches or resecting portions of muscles that are giving patients abnormal function. And so synkinesis is really a balancing act. So this patient, the lip elevators, which are here highlighted in blue, and the lip depressors here highlighted in purple, are pulling unequally. So she's getting too much pull down, and while she's trying to do a pull upwards, and so it's kind of causing this frozen smile where her the corner of her mouth just kind of goes out and it doesn't really go up. And at the same time, her orbicularis is activating more than it typically does, and it's causing the eye to be squeezed shut. And so patients who present, this is another kind of patient with synkinesis, and if you met this patient, it might not immediately jump out to you that she has had facial paralysis or this is something bothersome to her. But after Botox, you can see her smile is more symmetric. She has less squeeze around the eye. And this is something that really bothers patients actually. And they, you know, don't always bring it up to you. But there are some very simple treatment options that really help these patients. And this patient, she was really happy after these small improvements after a simple procedure such as Botox. This patient also has Bell's palsy, and this was before Botox. You can see, you know, similar situation where she's really got that frozen smile look. She doesn't have as much eye squeeze as other patients, as much ocular kind of synkinesis. But after Botox, you can see, yes, she has had improvement in her commissure elevation and symmetry, but it's still not perfect. And so, you know, we have therapy for these patients as well. And I work with actually one of the speech language pathologists in the Odo department, Emily Wilson, who does a lot of this therapy. And this is actually 3 months after Botox with therapy. And you can see the dramatic improvement, the kind of progression of improvement of her smile throughout those few months. And so by this point, she's actually worn off of her Botox, but because the therapy with the Botox has allowed her to improve kind of the movement of her levator muscle, and zygomaticus major, she's able to actually improve on therapy alone from before Botox as compared to with just Botox. And so therapy is a really important component for these patients as well. You know, this is a patient who really, she was just really bothered by the fact that her smile was asymmetric, and we did a selective neurectomy because she really didn't want to keep getting Botox to help improve her smile. And this might be a minor thing in the grand scheme of things, but you know, it's something that really bothers patients, and they really are much happier after simple things. And so, you know, this is a patient, for example, who has had right-sided facial paralysis and was just really bothered by the inability to kind of elevate his mouth all the way on the right side, and just a small amount of Botox into his depressors evens out the smile. And you know, this is something patients really notice. I don't know if you have any of you have ever had something like this happen, but afterwards your mind is just more attuned to looking at asymmetries in your face and picking up on that. And it lots of studies have shown increased rates of depression, anxiety, social isolation, and reluctance to kind of engage in a social aspect for these patients, because they, the asymmetries in their face are just more magnified. And from a functional standpoint, this patient, whenever she smiled, her eyes would squeeze shut almost all the way and actually block her vision in certain cases. And, after a small amount of Botox, she has improved kind of eye symmetry with smile. And this really made a big difference for her, although it was not necessarily perceptible to others as an issue. So moving on to flaccid paralysis, this is kind of the typical patient presenting with flaccid facial paralysis and, a faced nasolabial fold. He had a little bit trouble following directions here, but inability to smile. They can't hold food in their mouth. They kind of lose air when they're trying to speak. And the key for surgical options of flaccid facial paralysis is really the duration of paralysis. So if somebody has had this for less than 2 years, then their native facial muscles, so the natural muscles of their face, can still be re-innervated with other nerves. So we can put in other nerves to get that muscle back. After 2 years, the native facial muscles are atrophied, and there's nothing you can do for those muscles. And you have to really move in new muscle or tendon. Let's see. So nerve transfer options, there's lots of options. We can string nerves over from the other side. We can move a branch of the masseter nerve. We can hook into a branch of the hypoglossal nerve. We can take a branch of the deep temporal nerve of the temporalis muscle, or do any of these things in combination. And so this is a patient who, before and after masseter nerve transfer, she had a lot of, she had typical flaccid paralysis, and afterwards, much better symmetry, and then, much better movement as well. She did develop some synkinesis around the eye after this procedure, but, this was then treated with Botox. And so the key, I think, for the internist to know, primary care to know, is that if a patient's presenting to you and they've had facial paralysis, well, if they can get to an otolaryngologist or a facial plastic surgeon within 2 years, then their reconstructive options actually become much simpler and have better results. When they're over 2 years out of paralysis, then we're looking at muscle transfers as the primary option. And so the temporalis tendon transfers, probably the simplest type of muscle transfer option. It's an outpatient surgery. It lasts about 2 hours total. Patients have an immediate benefit to their resting position. And then they also have the ability to move their mouth when they clench their jaw. And so this is an example of a patient who, had flaccid paralysis and underwent a temporalis tendon transfer. And this is actually only after a month. And so he has a much better smile here than before. And then lastly, Gracilis free tissue transfer, something else you may or may not have heard about, but this is essentially a transplant from your own body. You take a piece of Gracilis muscle along with the nerve, the obturator nerve and the artery and the branch of the vein, and hook it up to, an artery and a vein in the neck, and then also to various combinations of nerves depending on that patient's particular anatomy and particular problem. And so this is a patient who, received a Gracilis flap. This was before. She has, again, flaccid paralysis on this side. And this is her a year after. And so the muscle actually takes some time to grow in. The nerve takes some time to grow in. And so she has to she's still learning how to use it. She's really learning to concentrate to pull that muscle to that side. And she's using a clench to be able to do that because we use the masseter nerve for her. So back to our goals. So I hope that we've able to talk a little bit about unilateral facial paralysis, workup and diagnosis. I think, the key here is to understand, for the vast majority of patients who present to you with presumed Bell's palsy, the natural kind of the initial presentation, does that fit or not? And then also how they recover. So are they recovering based off of what you're expecting? If not, then, you know, further treatment or diagnostic testing needs to be done, such as with MRI. And then 30% of those patients actually won't recover fully and may have synkinesis or other types of you know, residual facial function impairments that could be improved with fairly simple treatments. Types of facial paralysis, hopefully you have a good understanding now of the difference between flaccid and non-flaccid facial paralysis, and then also some of the surgical and non-surgical treatments for patients. And I think, you know, this is just a small snippet of the kind of overall care for facial paralysis. And I hope you were able to learn something, and feel free to email me with any questions, and happy to take any questions now.
Great, thank you so much for that overview. That was really helpful. If anyone has any questions, please feel free to unmute yourself and ask them, or put them in the chat as well. We can give everyone a minute. And then maybe while we are waiting for questions to come in, Alice, do you want to make your announcement right now really quickly?
Sure. Hi, everyone. I'm Alice. I'm one of the primary care R3s, in case we haven't met. And I sent out an email maybe last week or so about grant opportunities. So there's the Residency Diversity Committee, and we have some funding for grants. I will send out a reminder email today, just in case you didn't see it. The grant funding can be up to $500 per project, and we're really focusing on projects that are about promoting health equity or anti-racism within medicine, and that's pretty broadly defined. And the deadline is December 1st, but depending on how many submissions we get, we could be a little flexible on that deadline. So please apply and let other people know about this opportunity. Thanks.
Okay, thank you again, Dr. Liu. We really appreciate you coming and talking with us. If there's no more questions, we can take a break now, and we will return at 9:55 for our next speaker.
Thanks, everyone. Have a good day.
Thank you.
Thank you.